turn it over to the presenters.
Thank you, Alicia. This is Hunter Hurst, and I am a Senior Research Associate at the National Council of Juvenile and Family Court Judges. I will be facilitating the discussion today and am joined in that role by Leanna Kennicott of Futures Without Violence. Leanna is the Program Director in the Children and Youth Department of Futures. Please remember at the end of the presentation to submit a feedback survey and help us improve and plan subsequent webinars. I'm going to introduce the title of our presentation today and then introduce the presenters briefly and then turn it over to Leanna. Our webinar is titled Changing Minds, State Policy to Prevent and Heal Childhood Trauma, and will be presented by Laura Hogan, Debbie Lee, and Lena O'Rourke, all from Futures Without Violence. Ms. Hogan has worked as a senior strategist with Futures for 9 years on preventing and addressing violence. She has previously worked in philanthropy, Medicaid policy, and health centers. Ms. Lee is a senior vice president at Futures Without Violence. She has worked on the role of healthcare providers in violence against women, and more recently on child trauma and healing and efforts to prevent community and family violence. And finally, Lena O'Rourke is a longtime consultant with Futures. Her work focuses on Medicaid policy and advocacy strategies. Without further ado, I'll turn it over to Leanna.
Hi, everyone. This is Leanna. So like Hunter said, I'm a program director here at Futures Without Violence, and I'm so excited to be with you all today. I know many of you, actually. I recognize a lot of the names in the participants list. I'm actually on the steering committee for Linking Systems of Care and have probably met many of you at the All Sites or have learned a lot about you through the colleagues at NCJ, FCJ. I'm super excited to introduce some of my Futures colleagues to share some information that we've been really grappling with around statewide efforts around issues that you all are, similar issues that you are dealing with around addressing violence. And I'll just say that Futures Without Violence is a national organization dedicated to ending violence against women and children. We have offices in San Francisco, Boston, and DC. We're a national organization that's dedicated to sort of policy and practice change, as well as preventing violence, changing social norms, and we work with a variety of professionals on building capacity to better address violence. I'm going to turn it over to my colleagues, and in the end, I'll help facilitate conversation, but I'm just really excited to be here, and take it away, Deb.
Thank you. Yes, we are really excited to be here. I just want to back up for a second to say that Futures Without Violence has been involved at the national level around policy, and most specifically, you'll hear from Lena about our work around financing and Medicaid, as we are deep in on health issues because we run a resource center on domestic violence and healthcare. But also our colleagues Kirsten Stewart at NDC have been very involved in the Every Student Succeeds Act, Title 4A, which enables schools at the local level, the funding that comes down to address social emotional learning, and we were involved in the expansion of that language to enable people to work on child trauma issues using those funds. So we turned back in 2017, we turned our focus to states because we felt that in the current landscape that we might have opportunities as well as interest at the state level to expand the understanding of addressing child trauma. And we were looking at that, from an academic, economic, health direction, and wanting to really encourage the sectors to work together. So we kind of started that work gradually. You can go to the next slide, please. Oh, I'm going to the next slide. I'm sorry. I should be doing this. So we decided to develop develop a policy guide, but first, of course, wanted to get an assessment and see where states were at in their work and what the appetite was for such a thing. So we started by doing both interviews and a survey to various states that we had heard were interested in this. And as we went through this interview process, as you know, what oftentimes happens is that the people on the phone from one state say, hey, yeah, I work for the health department, and I know that this other state in the health department is really interested in this. And so we'd sort of follow the bouncing ball to open up these conversations with various different people. And what we really found was that there was great interest in the work at a state level, and that there were a number of initiatives that were funded to address this sort of cross-sector collaboration. So our interviews were to tap into and talk to people about what has been happening at a multi-sectoral level. So that included early childhood, domestic violence, healthcare, and education, and we really wanted to get the thoughts and viewpoints of researchers, advocates, and practitioners. The policy report, what really opened up was that people were in fact doing work in a variety of different areas. We wanted to touch on healthcare trauma in both in trauma education and in screening. We wanted to look at Medicaid as it is used to support screening, referral, linkages, and reimburse community health workers as well as, of course, clinicians. We found that there was a lot of work in scaling up home visitation, which is an excellent way to get to young families early, and a program that is well funded and spread throughout the nation. We wanted to see and look at the integration of both physical and behavioral health, look at services for families in CPS. Resiliency was a very important sort of approach that we wanted to highlight and explore, and also to look at the growing awareness that staff need to be trained around self-care. As we know, to support families and children, it is so important for staff to understand the trauma that they in fact have experienced themselves. And of course, the new practices for CPS and domestic violence involvement, and that the linkages between these systems is so key. As you know, in your own work, and as what we discovered back in 2017, there are a number of national initiatives besides linking systems of care, including Connections Count, the Neighborhood Community Connector to build social connections, Essentials for Childhood, which is, of course, stemmed from the effort to prevent child abuse, and, of course, Vision 21, multi-system efforts for victims. So the process that we use to develop this policy document, and it was a a real learning experience for us all was that first that we found that there was such great interest, because as we uncovered people's interests, they suggested other people, and as the word got out, there were a number of states actually that called us and said, oh, we heard that you're going to pull together a group of people, and so they were interested in also joining. And in fact, there were a couple states, I can't remember what states they were, but we had to turn away at the very last minute. But our process was to, as I mentioned, that we drafted a survey and did interviews. And then in June 22nd, 2017, we convened an in-person meeting with about 40 state and local leaders, federal partners, philanthropy, and national stakeholders, who met in D.C. We vetted our ideas with, of course, many stakeholders. And after that meeting, came up with a draft of a report and sent it out to everybody, and then had 2 webinars to get further input and critique on and comment on the report itself. So as I mentioned, we had a number of states. These were the 13 states from which participants came. And as I mentioned, I didn't say, but there are about half of the participants represented these 13 states. 25% of the folks were from local and national organizations, and 25% were funders and federal agency representatives. They represented healthcare, child abuse, education, justice, violence prevention, and other children's advocates from the community. Their expertise, included things in terms of public health approaches in this area, behavioral health, child development and youth leadership, community violence, education and school partnerships were strong. But there were a number of people who really had been doing multi-sector collaboration, not always including all of those sectors, but a very, very strong desire to do and an understanding that without a cross-sector collaborative approach, that they would not meet their goals. I think what was so surprising was the high commitment. Some of them had funding support for their collaborative work. 90% of those responding to the survey were participating in state-level coalitions working on child trauma, and others, came through the door of, at first, working on child abuse issues. Interestingly, there was experience amongst the group of some of the coalitions convened by governor's office with a heavy involvement of state agencies, and others that had more of a community organization membership. So when we pulled this policy piece together, we had a good discussion with the participants, and there were participants came from both red and blue and purple states. So we really knew that we wanted to speak to states who were not going to be, moving towards increased funding. I think in many, overall, as you know, I think the tone across the country is everyone is feeling pretty, strapped from a budgetary point of view. So we really wanted to have this piece practical. We wanted to address the impact on vulnerable populations and address disparities. Thinking across sectors, of course, was a big focus. And we really wanted to attend to both prevention and response, address financing, how to braid and blend funding, and we knew that states would need to tailor things to their own circumstances, as your initiative clearly lays out. It really has to work for the states. So there is a, the report really reflects a general recommendations and not, specific ones in terms of legislation at this point. So we were really looking at also near-term outcomes and not sort of high pie in the sky. So I think our feedback was, and what we tried to achieve, is a balance of, really specificity and readability. We recognize that states, as I mentioned, start at different places, and that equity and disparities is such an important thing for states to look at, and that states look at this very, very differently. Laura?
Hi, everybody. This is Laura. And, I do want to just offer a shout out to June Elstedt, who's on the call. She participates with all of you, and she actually was somebody who was at the in-person convening and, had a lot of good input to the state policy guide overview. So, June, I hope at the end, maybe when we're unmuted, you'll have some comments to make. So what I'm going to do is walk through some of the contents of the guide, and Debbie's done a great introduction to it. There's a lot of text on these slides coming up. I'm not going to read all of that text, but we did want you to have some of that detail for later, so it's on the slides for you to have to refer to in case you're wondering, what the crib notes version of the policy guide is. They're here on the slides. As Debbie was referencing, this state policy guide was really meant to be an attempt to present a gestalt view, if you will, not being pie in the sky in terms of the practicality approach, but to be ambitious in terms of looking at all of the things that it would take if we truly were going to prevent and address child trauma and violence. So there's a lot packed into these 5 goals that you see on this slide, and I'll go through each one of them, but intentionally this was meant to be everything that was the best practice, the best idea that people could bring forward from a policy point of view that would represent what they would want to achieve a true prevention and healing agenda. The first goal that was laid out by the participants was this idea of state-level collaboration and accountability. You're all participating in trying to link systems of care. You know how important that is and also how difficult it is. And so this state-level collaboration came in for a lot of good conversation from people. In some states, there is some type of state-level task force or collaborative body that's operating sometimes out of a governor's office, sometimes out of a different part of state-level government. And people really reference the importance of having that body for them to go to talk across the systems, to think about policy and financing and all of the other strategies that are embedded here in this policy guide from that point of view of how state-level collaboration can really advance the overall goals. We know oftentimes, for instance, that financing in one part, let's say in the healthcare sector, could be used to good advantage to take care of children who are in child welfare. So how can those conversations at a state level really address the mutual goals of helping children heal or helping them thrive? And the bullets that are on this slide were the participants' suggestions about what would be the purview of such a state-level collaboration. What should it do? And as I said, I won't go through those in great detail, but you can read them there. The next goal area had to do with innovation and learning. Very, very important, especially given where we are with these multi-sector collaborations and with child trauma. Both subjects still have more innovation and more learning to go, and it's important for us to be promoting this idea that we need to launch innovations in multiple sectors. We need to think about what they're trying to achieve and what they're learning along the way, and be able to feed out that information in as real a time as we can possibly do so that we can all improve our practices and improve policy to support those best practices without waiting long periods of time and without assuming that any initiative that's going to be mounted is the end-all and be-all. We are in an innovation and learning period of time, and you guys are part of that. The third goal that was discussed is workforce training and wellness. This is very important. What we discovered with workforce and talking about workforce training is that this is more important as a lever than solely as a content area. Very important content area to make sure that our child-serving workforce across all of the sectors is very schooled up in whatever the latest learning is, the latest practices are. We also discovered that as you do that workforce training, it becomes a point of system change. So once people are learning about trauma, once they're learning about brain development, once they're learning about new practices within their own sector, they're also questioning how that sector is really functioning, how well is it functioning, what else could we do to become more trauma-informed, to respond better to the needs that exist. And secondly, what can be accomplished through the workforce training goal is the very important area of self-care. We need to embed self-care practices within our systems. It allows folks in the field to be much more effective and to understand how to do their jobs best and how they can be the best that they can be. So it's a very important part of workforce training and referenced here as wellness, but is really all-encompassing in terms of self-care, healthy work environments, and responding to what people in the field need in order to be effective. The next goal is a huge one, prevention and services at the statewide system, and it covers 2 slides. I think this is a big one because almost every sector has a prevention arm, has a service arm, has multiple ways that they are delivering services in statewide systems, in local systems that roll up to statewide systems. This is really huge. And so some of the things here are at a fairly high level here. Very important to continue to bring forward the voices of people who have experienced violence and to embed that in our policy guidance and allow that to drive our best practices. And some of the other things here I'll say is that everyone is trying to move farther upstream in terms of identification, whatever system you're in, whether that's in a system where we know children have already experienced trauma, such as you're working in, or in school systems where we need to be better equipped to identify students who are in trouble, who are experiencing adversity, and then respond to that adversity at an earlier stage rather than waiting for families to really feel as if they're at the cliff's edge before we have services and practices in place to address that. The second part of this slide I'll just move to really talked about all kinds of things from community level collaborations that mirror that state level collaboration to specific ideas within sectors. So there should be stable financing for home visiting. Debbie already referenced that one. Health plans and medical homes should really become very schooled in trauma-informed practice and understand the whole continuum from prevention to healing, as well as the education sector and other child-serving sectors. The fifth goal, race and gender equity, we called out, although there was some discussion of equity becoming a cross-cutting kind of issue, and it really does belong in each of the goals that we've talked about so far, but it's so important to understand it and to analyze everything we're doing with a race and gender equity lens. And so the group felt this was important to continue to call out and to specifically address with its own policy and practices, rather than making an assumption that if it was embedded throughout the goals that it would receive the same kind of attention. And so the bullets you see here are a collection of things that hope to bring that race and gender equity lens to a policy approach. With that, I'm going to stop. We hope we'll have a great conversation as we open up the mics, but I want to turn it over to Lena to talk about Medicaid at this stage. Lena?
Thank you so much, Laura. My name is Lena O'Rourke. I am a consultant with Futures Without Violence, and I support their work on Medicaid and health insurance. And my presentation today, in addition to having less colorful and slightly more boring and nerdy slides, is going to be to really talk about how Medicaid works and how Medicaid pays for services. We'll look at the role of Medicaid as a key source of health insurance, but really looking at its benefit package and how that supports children and families. I want to acknowledge up front that I get that Medicaid is big and unwieldy. I get that it's complicated both for individuals to navigate and at a systems level, but it is super important to understand what it is, how it works, because it really pays for a lot, and how to understand that, to bring them to the table, and to work with them to develop systems of care that really work. So I'm going to outline how it works, what it does, and then the types of innovations that are already put into place with an eye towards looking at sustainable funding sources in Medicaid. So quickly, Medicaid, up front, here's what you need to know. Fundamentally, it's a health insurance program for children and adolescents, and I'll talk about it as a children's benefit, but really it's children and adolescents up to 21. It's a huge and important source of health insurance coverage. It covers behavioral health and healthcare services. It covers trauma-informed care and can be used in a lot of really interesting and different ways to look at prevention and early intervention and two-generation solutions. And it can be used in certain ways to pay for services that are for the benefit of the whole family and caregivers, so long as that service is in benefit for the child. We'll dig into that as we go. Medicaid is a huge source of health insurance. Every state has a Medicaid program, although it can be called different things in every state. Medi-Cal in California, medical assistance in Pennsylvania, all of these are the Medicaid programs. 1 in 5 Americans are covered by Medicaid, and children account for almost 4 in 10 of all Medicaid enrollees. Millions of parents are now also covered through Medicaid, particularly in the states that have chosen to expand their Medicaid program. There are gaps in Medicaid coverage, including for states that didn't expand Medicaid and for coverage of immigrants, but it is a program that covers a wide swath of Americans. Medicaid does provide comprehensive benefit package, and it is usually done through managed care. We won't get into the managed care aspect of it, certainly not in my presentation, but it might be something we want to dig into a little bit more in the question section. So keep that in mind, if that's interesting to talk about, we can get into that. So what's interesting about Medicaid, so much is interesting about Medicaid. One of the things that's really critical to know, though, is that Medicaid is a federal and state partnership. And that relationship is really important because within federal parameters, within the federal guidance, states really control a lot about the Medicaid program in their state and how it looks and how it functions. And states have a fair amount of control over their decisions. And there are different levers states can use to advance their health and population goals. So they can focus on different categories of eligibility, on value-based care, on improving managed care. They can look at systems of care or certain populations, or what we'll be talking a little bit more about population health goals, like improving the health system response to trauma. Each of these doors are touch points for advancing the kind of work you all are doing in your states. And this is the theme through my presentation, is that states can make choices to improve their Medicaid program, and those choices can be decided by the state within certain federal parameters. Digging in a little bit more, Medicaid does cover a huge benefits package, but notably it covers mental and behavioral health care. It covers developmental and behavioral health screenings. It covers assessments and treatment, and it is required to offer that in parity. Medicaid is required to offer all of its beneficiaries mental health parity. That is a federal requirement. And the behavioral health package, increasingly policymakers are looking at this as a way to do prevention and early intervention, particularly with a focus on healthy and resilient children. And that can be done in a lot of different ways, but increasingly looks at family supports as well and serving the family as well as the child for the overall benefit of the child. Digging in even a little deeper now, Medicaid covers services that are trauma-informed. To make that point and to be very clear about it, 3 agencies in 2013, July of 2013, released guidance on this to be crystal clear that Medicaid covers trauma-informed services. CMS, who runs Medicaid, the Administration for Children and Families, and SAMHSA, the Substance Abuse and Mental Health Services Administration, put out joint guidance that makes clear that Medicaid covers trauma-informed screenings and assessment, provides coverage of care to assess complex and interpersonal trauma, and for kids, provides all medically necessary trauma-informed care. The letter goes on to acknowledge that there isn't a DSM or ICD code for trauma effects, but it does say, it acknowledges that, and it says, and I quote, "Trauma-informed symptoms are identifiable, can be clinically significant, and can be addressed with appropriate interventions. For these children, appropriate screening, assessment, and referrals to evidence-based practices are clearly indicated." And then it goes on to talk about how all medically necessary trauma-informed services are covered for children. So it's a really powerful benefit that is baked in and acknowledged now by the Department of Health and Human Services as a core goal of covered services for kids. So then putting the pieces together, we know that Medicaid is a big source of coverage for kids, and we know that Medicaid pays for early intervention and prevention, and we know that states have the flexibility and the power to figure out how they want to accomplish their goals. So what I'm going to do now is walk through a few of the policy levers available to states. Each of these are options to states. They don't have to do them, they can do them. They are not necessarily easy. Politics and state programs and money, they all play a factor here, but every state uses these policy options in different ways, and they know how to do it. There are people within the Medicaid programs who understand state plans and how to navigate that. And I don't mean to minimize the challenges, but it is a matter of political will and energy and time and it's where advocates come into play to lift up the solutions they need and to work with Medicaid and other partners on solutions. So I want to talk through how to leverage the benefit package, how to include specific services in state plans, one example of an interesting intervention where peer-to-peer supports are covered, and then talk about health homes. These are all examples of state options. I think these buckets are really effective in building systems of care that really help wrap services around children and adolescents, but they are just some of many different types of models we could think about. So the benefit package as it is. For children and adolescents up to 21, the benefit package is called EPSDT, Early Periodic Screening, Diagnosis, and Treatment, but Medicaid people will call it EPSDT. It covers a lot of services, and most importantly, it covers services even if they're not typically covered by Medicaid. So for our purposes here today, it can cover comprehensive health and developmental histories, developmental and behavioral screenings, diagnostic services and assessments, health education, including child development and accident and disease prevention, and notably the treatment of all physical and mental illnesses and conditions. It is a powerful but a little slightly unwieldy benefit. We can unpack some of that in the discussion, but it is particularly important for children with mental health needs, with disabilities, with complex physical health needs, in particular because private coverage is usually inadequate in these circumstances, and because it is guaranteed to these children. The tri-agency letter on trauma does make it clear that EPSDT is the tool through which these services are covered, and that includes prevention. And through EPSDT, all necessary services do have to be covered. So the reason I'm going on and on about EPSDT is this is the door through which services end up being provided to any kid who has who is deemed any service for a kid that is deemed medically necessary. Medicaid must come in and pay for that service, even if it's not typically covered by Medicaid. So it's a powerful lever that states and advocates can work with to get actual services covered. Another lever that states frequently use is coverage of specific services or specific interventions in their Medicaid state plan. The state plan is what governs the state Medicaid program. It talks about what services and what providers are actually covered. And there are a lot of big buckets of coverage, and then there are also some specific services that will be covered. So to encourage the use of trauma-informed coverage or evidence-based interventions, or in fact to allow kids and families to get services together, it is possible to get these services included specifically in the Medicaid plan. Then, when a provider goes to bill for it, it facilitates an easier process because it is already a known covered service. So if you think about it in terms of like your employer health benefit package, you know what's on that list that's covered service. You know you get it, so you can go get it. It just makes things a lot simpler to have those services and interventions listed in the plans. Continuing to build this out and looking at a different model rather than a benefit model is this peer-to-peer supports program, which I think is a really interesting strategy that could be replicated to cover violence prevention. It could be used in a lot of different ways. Typically, the programs that exist in Medicaid today are for consumers who are in recovery from either mental health or substance use disorders, but there's nothing in the federal program that would limit it to peer-to-peer supports for adults with substance use or mental health disorders. The key here is that Medicaid will pay the peer providers to to deliver either one-on-one or in a group setting activities that really promote self-directed recovery through the peer model. Peer support providers must be trained and licensed, and the state must provide supervision and care coordination. So there are requirements to this, but it's a really interesting model that lots and lots of states have taken up in lots of different ways to support Medicaid beneficiaries through peers, and then it's paid like a regular Medicaid provider model. And again, in lots of states already, lots of states use peer supports to do different, to do some really different and neat things. And then finally, a lever I want to lift up for consideration is the health home model. To be clear, a health home is not a physical home. It is not a place. It is more of a construct of care coordination and care management that provides an individual with comprehensive services and care management and family supports and referrals and follow through on those referrals. And there has been good success in this model in helping individuals not just get referrals, but really get the care management and care coordination services they need. And states are increasingly using the health home models to provide targeted services to specific populations. Most frequently, that's beneficiaries with serious or persistent mental health disorders. But recently, last couple of years, New York added trauma and at risk for another condition as a qualifying condition for a health home, meaning that having trauma or being at risk of trauma in another condition is a pathway into these health homes that gets you this targeted care management and care coordination. And the New York model went live a little while ago, like 18 months or 2 years ago, I guess. And now they have a trauma-informed health home through the state Medicaid program in New York. So as a model in general, and then looking at New York specifically, this construct provides states an opportunity to really bring social service providers and to bring the whole care continuum spectrum to the table to help the beneficiaries who come through that door. So a couple of just quick things, and then I'll turn it back over for questions. But I can't do a Medicaid program presentation without at least talking about bringing Medicaid to the table. I think it's big and it's unwieldy. It sounds like at some level all of you are already engaging Medicaid, but I think thinking of ways to get them and to keep them at the table from the beginning and to build out solutions with them is a really smart step to consider. It's not always easy. Identifying the key staff within Medicaid does take some time, but asking questions with them and getting to know them, understanding what your state already covers in terms of benefits, again, not easy, but doable, and there are people within the bureaucracy who will know that. I think presenting to Medicaid why they need to participate with you, what the scope of the problem is, will really encourage the cross-sector cross-sector collaboration that's needed to really have a fulfilling conversation and to understand each other's point of view and to build a system of care that really works for children, adolescents, and families. I will say, to be really effective, it is important for all sides to be building the case of what is needed, and that includes surveying unmet need, evidence on why the interventions we're talking about work, identifying the types of providers that need to be paid for, and where there is unmet need in the provider space, and using data to the extent possible to show why investing in care and investing in systems of care really makes sense. And finally, thinking in partnership with Medicaid about ways to really blend and to braid existing funding. I know that's one of the core goals of a lot of these projects. Medicaid is a critical source of sustainable funding, but Medicaid has limitations on what it can pay for. It does not pay for startup and it does not pay for training, for example. However, there are services and providers that are paid for by Medicaid that could be supplemented by Medicaid funding, replaced by Medicaid funding, and bringing that journey along, bringing them along on it will really let you see more specifically how Medicaid funding can be leveraged to really support kids and families. So I want to mile a minute there, but Leanna, Hunter, let me turn it back to you guys.
Can you hear me?
Yep.
So I think we had a couple of questions in the chat for you specifically, Lena. So can families access the Medicaid benefits if they are not already receiving benefits?
So I'm gonna take a stab at answering that. Michelle, if I'm not actually answering your question, if you could type it again, and I'm happy to clarify. So the question is, I'm going to go ahead and interpret this, is can the family get in on the kids' care if they are not currently covered by Medicaid? And look at that. All right, so that's the right question. So yes and no. It depends. And that's going to be it's kind of it becomes a joke after a while because I'm going to say yes or no, it depends on the state to almost every question that I'll get asked today. But yes, they sort of can. And I think this is one of the new opportunities under Medicaid. And Medicaid is really moving in this direction, and it's great, where so long as the services are for the benefit of the child, family care can be covered. Now, that has been defined pretty narrowly so far. A really good case study for this is maternal depression. And maternal depression screening, and in some states, treatment, can be covered by the child's benefit. So you'd give the kid's insurance card, and then the mother could get care. Because it is so clearly linked that maternal depression has an impact on the child. In some cases, in some states, family therapy, group therapy, and other interventions where the model is to serve the family together to build stronger and more resilient families, that can be covered by Medicaid and is in a number of states. But I'm making up this example, but I think it'll illustrate the point. The mom would not be covered for a broken arm under their child, for her broken arm under the child's health insurance. It's services that are designed to support the child's health and well-being. There are not exactly limits on what that list of services that would be. That really is going to be state-specific. So some of the evidence-based family therapy models are specifically covered by state plans, and you'd have to kind of unpack that in your state. But that's where that would be a really good example of where you'd be able to treat the whole family on the kids' health insurance. That maternal depression piece is a big one, and there's lots of work, and we could pretty quickly pull together some resources on what that would look like. And others on the phone actually may have more to contribute to this. Laura, Debbie, Leon, if you know of any as well, please share, or you may know of some of the programs in the state. But it's an emerging field. It's not moving super fast, but I think it is an interesting way to think about this.
Well, I think one of your points, Lena, is that linking systems of care sites have a huge opportunity to sort of expand what could potentially be covered, right, and influence that conversation, given that they are identifying unmet needs, they're identifying all kinds of sources of victimization for children and adolescents in their state, and are trying to connect providers, right? And I think many are struggling with trying to, they're identifying folks, but then not actually able to get them into services. So I think influencing that conversation on a state level is a key step for these sites. So Lena, if folks were to take one action step around this, it sounds like you suggested identifying key folks around Medicaid, how would they go about doing that? I know you said it was challenging, but what could be a starting point for them?
So I'll say these in an easy breezy way, and I want to acknowledge that it's not necessarily that easy, but I think just the first step would be finding the right people who work in the agency. There are going to be a lot of different doors. Medicaid state agencies are huge, but thinking critically about what department. Do you need somebody who deals with benefits? Do you need someone who deals with schools? Do you want somebody who really knows EPSDT? I might go with that one. And calling around till you find them. But there will be pathways within the agencies, and I think it'll become clear which departments you want. The reality is, I've worked on a lot of different projects trying to integrate state Medicaid people into partnerships like this. You might need more than one person. You might need the Medicaid managed care person and the EPSDT person and the schools person. And they're going to be three people with three totally different backgrounds and knowledge and ability to help you navigate. So the more and the richer those individuals you find are, the better. But I don't think you can go wrong by just starting. I do recommend bringing Medicaid to the table as early as possible. For discussions, I think it's this space of really linking systems of care across different agencies is kind of new to the Medicaid model over the past bunch of years. But from an advocacy point of view, having them there to guide the conversation in the beginning, it does help. But sometimes it's just really finding a person and starting with them and then navigating from there. I mean, it's networking and thinking strategically about what skill set and knowledge base you need. What questions do you want answered?
Thank you. So I'm hoping we can unmute participants, and if there are sites that have engaged in conversations both on sort of what the Laura and Debbie talked about in terms of state policy organizing collaboration efforts, or what Lena talked about in terms of engaging Medicaid. If anyone would like to share either a success that they're having or a struggle that they're experiencing in terms of the work that they're doing in their site, we would love to hear from you. So Alicia, is it possible to unmute folks? Or raise hands?
Everyone should be receiving a notification shortly, if you didn't already get one, that you've been unmuted. If you would like to talk over the phone, just raise your hand using the raise hand feature at the top of your screen. There's a little icon of a person with their hand raised. If you click on that, it'll let us know that you want to talk, and we'll just go down the list.
In the meantime, while we're waiting for that, I had questions about, well, actually, we did some pre-questions when folks registered, and in linking systems of care, some of the linking is with systems that serve youth that are juvenile justice involved. So I was just curious if the levers you were describing can be used that way.
Yes, totally. It depends on the state. Medicaid cannot provide services to any beneficiary who is incarcerated, but justice-involved populations, if they're otherwise eligible, many of them are able to get and receive Medicaid benefits. States make a lot of decisions on that. And there are lots of different rules about when you can use it and when you can't. And I'll be honest, that one gets a little out of my scope because they're so state specific.
Okay.
But it's it is an emerging area of policy where there is, I think, really increased awareness that of the importance of health insurance while you are particularly coming out of out of a justice system and back into those transitions in and out, I guess, is what I'm really trying to say, that coverage and care is really important. And states are making a lot of choices to help just suspend the Medicaid coverage instead of stopping it. So what point that starts and stops will change based on the state, but states do have that as an option to suspend coverage during periods that they're not allowed to cover people who are involved in the justice system. But the short answer is yes, it's going to depend. It is a topic very much worth looking into and thinking about how to increase the coverage rates at every point of that system. But what counts as in the system and not able to get Medicaid, I can't speak to, but we could send some resources on.
And
I was wondering
Hunter,
maybe
this is Laura.
Oh, hi.
Sorry.
Go ahead.
This is Laura Hogan. I just wanted to agree with everything Lena said and say that there are some really interesting programmatic models that are coming forward, both on the coverage side and how to go into justice facilities, including juvenile justice facilities, and make sure that people are sort of pre-enrolled, connect them into that enrollment system if the state has not just suspended their enrollment, to connect them to coverage before they transition out. And then secondly, clinic providers are starting up programs under a model called transitions clinics. And these are clinics where there is a provider and usually a community health worker person with lived experience who are specifically put in place to care for the range of issues for somebody coming out of a justice system. Those are not very widespread, but there are write-ups of that model, and there is a little technical assistance network that's operating. And so if people are interested in more information on that, I could offer some links.
That would be great. You anticipated what I was going to ask, which was if there's some profiles, like a way to explore the states that have developed solutions for that really challenging transition situation.
Happy to do that.
So do any of the folks on the call have any questions they want to ask the presenters, or share any of your successes or struggles in engaging in this sort of statewide work? I don't want to call out, but I do know that Virginia and Montana, that's the two sites I'm most familiar with, have been trying to have some of these conversations. So we'd love to hear from your experience.
So this is Jess Neighbor in Montana. I'm the policy coordinator here for the Linking Systems of Care project, and we've had some interesting changes in the Medicaid expansion we had in 2015, which was a boon. We had roughly 90,000 people sign up for Medicaid after the expansion. However, in November of 2017, our legislators decided to create a mechanism by which if there was a budget shortfall, they'd take it out of Medicaid. So we saw a big slice taken out of Medicaid, which resulted in loss of caseworkers across the state, loss of mental health services for kids specifically. Just recently, the legislature came out and said that they were going to restore some of that funding, but we've just had a whole lot of shakeups as a result of the Medicaid expansion. So a lot of it has been promising, but it's also been challenging. And now we actually have a proposed $2 a pack tax on tobacco going before voters, and that could help expand Medicaid. So we've been on a bit of a Medicaid roller coaster, but certainly we see the value of Medicaid for our project in that it helps kids get to mental health assessments if they show a red flag through screening, for example. So that's kind of our Medicaid update. We have made friendly with many of the Medicaid administrators, and just during this particular webinar, I put a star on my notebook to invite one of the administrators to join our policy work group, as I hadn't thought about that. I think it's a great idea. So that's just kind of my rambling update about Montana and Medicaid.
Thank you. Lena, any words of wisdom given that roller coaster that you just heard?
No, but you know, keep your chin up. We're all rooting for you.
Yeah.
I mean, well, I can answer more specifically too, which is, I mean, unfortunately for the people who rely on the program, Medicaid has become awfully politicized over the past couple of years. But I think will continue to be in the short term. I think, though, there is growing acknowledgement of the role that it plays in supporting children and families and adults and people at various transitions in life, and increasingly telling that story and showing the ways it links with other systems has been shown in many states to really be an effective way to bulk up and to bolster the program. You know, even when it's a political hot potato, states are still still participating in the program and investing in different ways and using the flexibilities to really support their population health goals. And the programs aren't going away. They're just, well, I mean, they are going away for some people, but the overarching program isn't going away. And building a case that investing in various programs has a benefit to the state, and I think you are uniquely positioned to show the benefit to various other departments of really building these linkages. I think it's only good for the Medicaid program in the short and in the longer term. And I think demonstrating the data in terms of coverage and outcomes for different programs and how they are intertwined and linked, and that you can't do these pieces alone, is a really important part of the way that, you know, to shape the Medicaid program, but also to show its value for different populations. So, I mean, do hang in there. Do remember that this is important, and I understand, and we are all, you know, everyone's doing what we can to find a way to stabilize these programs, but, you know, understanding ways to shore it up, I think it's an important conversation to be having at the state tables.
Mm-hmm. Thanks.
Our linking systems of care colleague, Erin Branch, has a question. She chatted. Do you find that the conversation around evidence-based interventions creates challenges for getting Medicaid to cover services that support healing?
I certainly have an answer, but Debbie or Laura, would either of you like to tackle that one first? All right, I'll jump in. So it is a challenge, but it is not impossible. Evidence-based practices in medical services and ICD codes, and it is easier and simpler. That's how the program works. I think increasingly, though, looking at the care coordination models and more focus on prevention and early intervention is increasingly looking at ways to cover services that promote healing and models of care that are beyond just an evidence-based intervention. It's certainly something we at Futures have spent a lot of time thinking about and really support different models of it. It is a challenge, particularly under the EPSDT, because it does require medically necessary services. So it gets not impossible, but harder to talk about and to model. I think, interestingly, managed care has a lot more flexibility to provide systems of care that bring in different types of providers and non-medical providers and more types of services provided by advocates and other promotoras and community health workers and other types of solutions that really promote healing. I think managed care has more flexibility, and increasingly state Medicaid programs are looking in those directions too. So I think it is an emerging field, but one that is worth thinking critically about in the context of sort of the bigger healthcare system. It's not just Medicaid. It's all it's the whole healthcare system.
Right. Well, this is Leanna. I was just going to, oh, go ahead, Deb.
Yeah, I was, sorry, I was talking, but I had myself on mute. It's the question about whether Medicaid colleagues need us as partners, right? It is so true that I think what you all really understand are both, in particular to me, not only what the kids need, but also what is a two-generation approach, which I think is still so much of an upward learning omission. And so, really how these things, how, investing in moms can, and whoever the healthy parent is, can really, benefit the kids as well. So I just wanted to add that.
Mm-hmm. Well, this is Leanna, just to add to the evidence-based sometimes conundrum. I mean, I think the different kinds of interventions that have shown evidence has greatly expanded in previous years, but we still have a long way to go in terms of working with culturally specific and marginalized populations. And I know, specifically in Montana, the interventions that, have had more formalized evaluation around tribal communities is even lower. And so I think that is definitely a struggle, and I know I've heard that from some of the sites is, okay, we have, one TFCBT provider in the state, but there's no cultural relevance around that intervention for this population, right? So I do think that is something that we really need to struggle with as a nationally around building the evidence for different kinds of models, building models from culture up, right? And not necessarily requiring randomized control trials for everything to be covered or approved or to show up on a federal database of approved interventions. So I think some of the work that we're doing under PHPSA-funded Promising Futures that some of you may have heard me talk about is really trying to expand the sort of evidence-informed and practice-based wisdom that we know around what works with families and kids, and to think beyond just high-level clinical interventions, because so many of the families we're working with don't necessarily need high-level clinical interventions, but could really benefit from other kinds of services that can be more community-based and are not clinician-driven, right?
And this is Laura. I want to chime in here, partly to pick up the thread that Lena was on about how connected this topic is to the whole healthcare system change. And so I know that there are many states who use what's called their state innovation model grants, which are big grants at the state level, or their Medicaid waivers, which are also big programs at the state level, to work on whole system changes within healthcare. There are so many people now on Medicaid in many states, 1 out of 3, 1 out of 4. It is a big driver of the healthcare system. And if you can get something to work in Medicaid, states often find that it will be done by the whole healthcare system because people aren't going to single out in their health practice. They're not going to single out people by the insurance card they come in with if we're talking about a generalized practice. So many of these changes have to do with earlier identification, prevention, and trying to move upstream with the needs that people have before they experience, a diagnosable health condition. And the reason I mention that is because that would not appear on the horizon as a trauma-informed initiative or even as a children's initiative. It would be operating probably within the healthcare system and the healthcare settings, but it does have implications and it does improve the situation that exist for those experiencing trauma and for children specifically. So I do just encourage you, as Lena was saying, to try to get messy with Medicaid and what's going on in your state, and you may find that there are some very important changes in the healthcare system that aren't called trauma, but that very much improve your chances of getting kids the care that they need.
We have some observations from our participants that they've chatted. June from Montana has indicated that it appears the Rocky Boys Tribal Health is going to fund their crisis treatment home completely on Medicaid. And building the home, of course, needs a different funding source. And we have a question from Denise Perry. How do you suggest dealing with trauma-affected juveniles that are acting out violently, substance abuse, to the point they require detention before services start and once in detention? Medicaid is no longer in place, and they have to release and start services, but the services have to request or start a process once again when the juvenile is released. We talked a little about earlier about this. It feels like an endless crazy circle for them, and any suggestions?
Well, it seems to me in some places there is more attention now to kind of intermediate care facilities from stepping down from an actual juvenile justice facility, incarceration facility, to something where Medicaid services can be provided, but it's a fairly safe and controlled environment, like a residential treatment, but it may not be actual residential treatment because maybe you need the Medicaid benefits to get yourself into that. I know there are some intermediate step-down type facilities operating in California for prison. I don't know of those for juvenile justice, group homes or something like that, but others on the call from other states may know of something that is operating in between true, incarceration type facilities and juvenile justice facilities and just being released into the community.
And it was mentioned earlier, there are some state a handout, possibly subsequent handout of that's specific to one state in terms of this kind of cycle. Is that correct?
Yes, in California, I can offer links to that kind of an approach in California that's being used.
It's specifically California. Okay.
Mm-hmm.
Okay, anybody else want to be unmuted and ask a question? We have about 15 minutes left, and we can either continue talking or give everybody the gift of time and end. I see Aaron is typing a question for us, or an observation. Okay, from Aaron, knowing our partners at Futures, as we do, I have to ask, how does Medicaid respond to domestic violence and sexual assault? How can we help them be good at it?
So I'm going to answer the first. This is Lena. I'll answer the first piece of it, and then I'll turn to my colleagues for more. So Medicaid covers the services that are in their Medicaid state plan, and that'll depend on the state. Medicaid covers screening and brief counseling for DV and IPV. And for children and adolescents, that will include the whole EPSTT benefit and all the services that are medically necessary to heal and to treat. For adults, the benefit package is more limited, but it is required that they cover all the essential health benefits, including mental health care and mental health parity. So Medicaid, it depends on the state, but the states do cover this DVIPV screening, and then a whole range of other benefits that are there to support the needs of survivors. But, as with anything, well, with health insurance, it is transactional. Either the benefit's covered or not, and then they'll pay for it if it's served. I think the greater piece of your question, Erin, is that second piece, how can we help them be good at it? And I think, Laura, Debbie, maybe I'll turn to you guys to answer that question a little bit more.
Debbie, are you there? This is Laura. I can jump in.
Yeah. I think it's really, again, just educating, doing a lot of educating of Medicaid, and then I think almost, I don't know if you all would agree, but I think it's also educating the providers about how they offer better services to victims as well.
Earlier, I had kind of skipped it. Erin had asked, do our Medicaid colleagues need us as partners? So our Linking Systems of Care Virginia, and so forth. And if so, what can we do to facilitate that they can't? What can we offer?
Well, this is Laura. I think I think absolutely the answer is yes.
Yeah.
They
need you so much.
They do. I think it's really a bidirectional partnership that is needed. How can Medicaid offer services to heal and benefit the health of the youth that you're working with, and how can you, on your side, identify those health needs in ways that kind of fit the Medicaid picture so that they understand it, and help youth actually access those services. I think the navigation is a very big piece of this, and there are actually Medicaid funds available for navigation that are greatly underutilized by states. But I guess I would say it is very much bidirectional. I think it's to mutual advantage to form those partnerships, and you have a lot to offer Medicaid, as well as Medicaid having services to offer to you.
The only thing I would add, and this is Lena, is Medicaid sometimes speaks a different language than other silos, and I mean that figuratively and somewhat literally. And I often feel like I need a decoder ring that translate what the Medicaid people are talking about. And it's just something to be aware of. I think Laura's points are all just spot on about the bidirectionality of these conversations and what a mutually beneficial partnership it can be. I think a big first step in that, and maybe something I would add to the how do you start the conversation, is to really develop a common language, a shared understanding of who these children and adolescents are that we are trying to serve together, and what that looks like. And Medicaid talks a lot about unmet need, and their language might be different about who these kids could be and what the problems they're seeing. But developing that shared understanding and common way of talking about these patients and these services that they need is a role you can play, and I think it's an important one. That translating function it feels so basic, but it ends up being much more of an obstacle sometimes than you think. So thinking about that and what you can offer, and remembering that sometimes it's just about listening to what the shared language is, I think is an important step too.
Okay, I'm sorry, I unmuted. We have a question from our colleague, Michelle Robinson, and she has asked, Lena, thinking towards sustainability to linking systems of care projects, can you provide more information on Medicaid covering screening processes?
Yeah, no, I can't provide preferred screenings. What I can say, and I think to be accurate, and if I'm wrong, we can double behind, is many states, well, it depends on the state, but many states defer to the AAP periodicity schedule in terms of screenings, in terms of what that looks like and what they cover. But in terms of the actual screenings and interventions, that gets a little bit out of my purview, in both in terms of what is desirable and how that works. But I know there's a great reliance on the AAP screening guidelines. Laura, you might know more about this. Do you have a better or fuller answer?
I'm not sure that I do. There's screening and there's kind of care coordination navigation that I was talking about before, and in some cases those things can become helpfully put together. So there are Medicaid funds at the state, administrative type Medicaid funds that are administered usually at the state level for getting people eligible, or figuring out if people are eligible, getting them enrolled and getting them into Medicaid, and then coordinating access to care and handling all the care management needs that a person has once they get onto Medicaid. And those are the resources I was talking about earlier tend to be quite underutilized at the state level. They may be operating in a public health department to a limited fashion, but are not necessarily broadly available across different systems and even with community-based organizations. However, there's no prohibition, there's no requirement that those operate only within public health departments. They can operate in child welfare, they can operate in mental health, they can operate even in community-based organizations. It takes a lot of advocacy to see your way through to having that happen, but there's nothing in the regulations that means that lots of people can't participate in that kind of care coordination and care navigation. And I guess I would say, to the extent that you can embed screening in that kind of language, I think, yes, it could cover screening, but I would not say it is primarily a screening process as I know we're actually talking about it here. The other thing I think I would say in all these topics of, whether it's covering screening, bidirectional partnerships, is that, as Lena is saying, there's a lot on the books that allow Medicaid to be a helpful resource and a helpful support to what it is that you're trying to do. And don't underestimate your role as someone who's, calling for that to happen in a way that is accountable and collaborative to serve kids the best you can. So because there aren't enough programs, because there aren't enough services, is not a reason to stop the conversation. It can be the beginning of a conversation, and what are the ways that you can use data, that you can keep the conversation moving about the fact that youth do tend to cycle in and out of programs, they tend to get worse. I mean, all of the information that you have on your side of the partnership that can be very, not only credible, but very motivational, I guess, to get more services moving that are missing. So the Medicaid program may not be very aware of all the missing parts or what all the needs are or what all the programs are that could be in use in a locality, and that's that's how you can be a helpful partner to them, as well as employing them to use the resources as expansively as possible for things like navigation that I was talking about before.
Oh, thank you. Do we have any more questions before we end? We've only got a few minutes left. Okay, I think we will close at this point. I want to sincerely thank Laura,